So, hello friends. So today I'll be giving an overview on this journal update on certain practice-changing articles that have come in Neurosciences or Neurology. So this was part of our bicep workshop that, bicep meet that happened on 7th February. So what I've done is try to pick up the practice-changing articles that have come in last 1 year, that is from 2024 until date, to see what are the key ones that may have influence our practice. So when I say practice changing, again, for all our intensive care trainees, what it really means is we pick up the top impact factor journals like from NEJM, Lancet, or JAMA, because they are the ones which come with these multicentric sort of a randomized control trials, which may have bearing on the change of practice. So I picked up 5 trials because this talk was meant to be for 12 minutes. So it's a short time. So I think 5 articles should suffice to cover, and I may exceed the time also. So the first trial that I'll be talking is the Hemotion trial. So just for all the trainees, remember the name of these trials, because that is also sometimes important when you have citing, especially in your exams. So this was a Canadian trial that came in NEJM in 2024. So this particular trial was done in traumatic brain injury to see whether we need to maintain liberal transfusion or restrictive. So for all the intensivists who are listening to this, I'm sure we're all adept to the concept of being restrictive, isn't it? Like we don't want too much of hemoglobin. So for us, 7 is perfectly fine. So whether that is true with traumatic brain injury, this is symptomatic traumatic brain injury. It means they were sick patients to look at liberal. So what did they mean by liberal? Liberal is where they maintained hemoglobin more than 10. So they only gave blood if hemoglobin was less than 10. So of course, for all our listeners, we know for ICU, for most critically ill patients, we agree 7 is good enough. So the restricted was to see whether 7 was good enough. If it was less than 7, they gave blood for these patients. So the primary outcome in this particular study was to look at unfavorable outcome. So unfavorable, they look at Glasgow outcome score at 6 months to see whether it had any bearing, this transfusion thresholds. So the secondary outcomes they looked at was mortality, they looked at functional dependence and quality of life and depression at the end of 6 months. So these were some of the secondary variables they looked at in this particular Hemotion trial. So as I said, I've already put the terms. It was a equivocal, which means there was no sort of a difference between restrictive. So that's the summary. So when you look at the results, so this was a good study. 742 patients they took. 371 were in the liberal, where they maintained hemoglobin 10 and above. Restrictive, where they accepted 7 and they only transfused if it was less than 7. So they looked at median hemoglobin. Of course, median hemoglobin in liberal, it was maintained at 10.8. In restrictive, it was 8.8 at the end of it, because they did give blood if it was less than 7. So they looked at unfavorable outcome, because the primary outcome was to look at Glasgow outcome score or the functional outcome. So they looked at unfavorable outcome, whether there was any difference between liberal and restrictive. So as you see, it was liberal, it was 68.4, restrictive 73. And if you see the confidence interval, it was not significant, which means there was no difference between liberal or restrictive group with regards to the transfusion thresholds in traumatic brain injury. And most important for intensivists, we look at mortality. There was no difference between liberal or restrictive group. And the secondary outcome they had to look was at depression at the end of 6 months. Even that, there was no difference between liberal or restrictive. And functional independence as a secondary outcome was found to be higher in liberal, which means they became little more functionally independent. And they looked at venous thromboembolism, because when the contention would be that you give more blood, they may be at a risk. So there was no difference between liberal or restrictive group. And they looked at ARDS. In fact, they found the risk of ARDS or the occurrence of ARDS was significantly higher in the liberal group. So we all understand that. That's why we don't give too much blood, because more blood you give, there is a risk of causing Crowley and ARDS. So ARDS definitely was more in the liberal group. So these were the findings in the Hemotion, which basically said that we can stick to our restrictive policy, that hemoglobin of 7 is good enough. We don't need to target 10, because even the risk of ARDS was found to be higher. So I'm sure most of the listeners will get excited, will say we'll stick to this until A similar trial came in 2024, which again debunks it. So that is a trained randomized control trial. So the conclusion they made was in patients with symptomatic traumatic brain injury, so the liberal transfusion did not make any difference in reducing unfavorable outcome at the end of 6 months, which means giving blood unnecessarily did not change any functional outcome. So this makes all intensivists happy that yes, that has been our practice. We have been maintaining hemoglobin at 7, so that seems to be good enough. We are preventing until this new trial came called the trained randomized controlled trial, which debunks our whole understanding. But here they took acute brain injury. So see, this came from the Brazilian and the European group. So restrictive versus liberal transfusion strategy in patients with acute brain injury. Here, along with traumatic brain injury, they took all other patients also. Here they look, see, if you saw the previous Hemotion, they maintained hemoglobin of 10 as liberal. In this trained randomized, they took hemoglobin of less than 9. They gave blood, and less than 7, they gave blood in restrictive group. There it was 10 versus 7. Here it was 9 versus 7. So it was a multicentric, open label, randomized controlled trial from countries from Brazil and Europe. 72 ICUs were enrolled across 22 countries. So this was a huge trial, very similar to the previous trial that came from the Canadian group. But here, the inclusion criteria, the previous Hemotion trial was only traumatic brain injury. Here, they took traumatic brain injury along with ischemic strokes and intracranial hemorrhage, and they took subarachnoid hemorrhage. So they took all acute brain injury patients. So the inclusion criteria is anyone with hemoglobin less than 9 within 10 days of admission to ICU they took, where the expected ICU length of stay was more than 72 hours were taken into or enrolled into the study. So this was the inclusion criteria for this study. This came in JAMA. The previous one came in NEJM. So very similar to the last trial, but here they took ischemic stroke, they took subarachnoid hemorrhage, they took intracranial hemorrhage, and traumatic brain injury. So they took all these patients. So here the primary outcome was to look at unfavorable neurological outcome. There you saw it was at 90 days. Here they took unfavorable neurological outcome at 180 days. And they looked at Glasgow outcome score, very similar to the Hemotion trial. So the mean age of the patients was 51 years and 45.9% were females. So last study you saw around similar number of patients were there. Here they had 806 patients. And of course, the median blood that was needed in liberal group was more. So they needed 2 transfusions as opposed to 0 in restrictive. The mean difference was 1 unit. So when they looked at unfavorable neurological outcome at 180 days, which was also the primary outcome in Hemotion, it did not show difference. But here, if you see, the unfavorable outcome was more in restrictive, which means this trial debunks our thought that restrictive is better. Basically, unfavorable outcome was seen in restrictive group at 72.6%, as opposed to 62.6% in liberal. That was statistically significant. And even the ischemic brain injury, so the ischemic deficits in the brain was also more in the restrictive. So they had 13.5% as opposed to 8.8%. And if you look at the confidence interval, it was statistically significant. So basically, this trained randomized controlled trial debunks our understanding that restrictive is safe. It basically says you may have to go liberal in these patients because it led to better neurological outcome, and your neurological ischemic defects or ischemic brain injury was less in liberal group was found. So the conclusions they made was the patient group which got liberal transfusion had lesser unfavorable neurological outcome at 180 days. So this really puts up a discussion to, or puts all the intensivists into thought whether should we really go restrictive in acute brain injury, because we were accepting 7. So perhaps maybe now we may have to look at maybe 9, so on and so forth, because at least 10 we don't need. So at least should we consider 9 is what is a thought that we should bear, especially looking at this trained randomized control trial, if you have to vouch to it. So I leave that to your discussion and your interpretation of this. But these are the 2 trials which are quite divergent, because the Hemotion trial said 7 is good enough, but now the train says no, 9 is better because it leads to better favorable neurological outcomes and your ischemic defects are less. And but on the contrary, the Hemotion trial said ARDS was more if you give liberal. So it is a balance. So you have to put in your clinical context. So so the next two trials, they are also divergent like this. So I've only picked up the trials which contradicted each other in last 2024. So you'll see the next two trials, which are again very interesting. So this was a trial which is a last trial, LAST, last trial, which came from the French group. Again, this came in NEJM in 2024, trial of thrombectomy for stroke with a large infarct. So here they took patients with a large vessel proximal anterior circulation infarct, so anterior circulation stroke they took. So this whole yellow thing is the stroke. So here they looked at all the patients with an aspect score, which is Alberta stroke program early score, less than 5, who underwent MRI basically within 6 hours to as an inclusion criteria into this. So this was the inclusion criteria. Large proximal vessel infarct with ACA territory and who came within 6.5 hours, who could undergo CT angio and MRI. So they were included in the study. Okay. So here the two groups that were compared were patients who underwent mechanical thrombectomy with standard medical treatment, which may include thrombolysis, so on and so forth, versus patient who did not undergo thrombectomy but only medical therapy. So these were the two groups that were compared. Primary outcome was to look at modified Rankin score at 90 days, which is categorized from 0 to 6. 6 indicates severe disability and 0 is normal. Okay, so they looked at as a primary outcome. So the safety outcome they looked was death of due to any cause at 90 days or symptomatic intracranial hemorrhage. So as an adverse event outcome that they looked at. So these were some of the things they looked at. So this was a hugely positive study. Basically, it said do thrombectomy with medical therapy leads to better outcome. But hold your breath, because after this you will see another trial which goes divergent, like the Hemotion and Train. So here they took 333 patients, 166 who underwent thrombectomy with medical therapy and 167 in control group. Modified Rankin score at 90 days was, as you see, was better, was 4, and it was bad in control group, and odds ratio was 1.63, and that was statistical. Basically, it said your neurological outcome score was better in thrombectomy group because your modified Rankin score, lesser it is, better it is. It was less in thrombectomy and more in control group. And look at the death. Even the death at 90 days was significantly less in the thrombectomy group at 36.1% as compared to 55.5 who underwent only medical therapy, and that was also statistically significant. So basically, it was a hugely positive study which said within 6.5 hours, someone comes with a large proximal vessel ACA territory, do thrombectomy with medical therapy, leads to better functional outcome and better sort of a survival. But they look at the symptomatic intracranial hemorrhage. As you see, it was higher even in this study with thrombectomy group as compared to the control group, it was higher. So adjusted relative risk was 1.73, and that was significant. So, and the procedure related complications was found in 11 patients in this particular study. So the conclusions they made was patients who underwent thrombectomy with medical therapy had a better functional outcome with reduced mortality, but the patients who underwent thrombectomy had increased symptomatic intracranial hemorrhage, which was the limitation of doing thrombectomy. So we all get excited and we can say, okay, it's come in NEJM, great trial. So last trial from the French group until we got Tesla randomized control trial that came from US group. So very similar, like you saw the Hemotion and the Train randomized, this Tesla randomized control trial, very similar, came in JAMA. So there also you saw Hemotion came in NEJM and Train came in JAMA. Here you are seeing the one which came in NEJM and now the Tesla coming in JAMA. Okay, so the last came in NEJM, the Tesla. So this trial was done by US group, same design, proximal ACA occlusion. And here, what they did was they took same patients with aspect score of 2 to 5. There also you saw less than 5. But there they took within 6.5 hours. Here they took patients within 24 hours after CT injured. So here the window period was much prolonged. They took the patients up to 24 hours. What did they find? So very similar, they compared thrombectomy with medical treatment. Primary outcome was utility weighted modified Ranson score. There you saw 0 to 6. Here it was little ulta because it's a utility weighted. 0 is death and 10 is no symptoms. 10, so higher score was better here. Adverse event, they looked at primary outcome at 90-day mortality. At the secondary adverse event, they looked at symptomatic intracranial hemorrhage. So very similar to last time. I mean, the previous study, the last trial. So, and very similar number of patients. Even the last trial, you saw it was around 300 odd patients. Here also they had 300 patients, 152 in the thrombectomy group and 148 in the control group. So, utility weighted modified Rankin score was no different. So, there you saw the functional outcome was much better in the thrombectomy. Here it was very similar, 2.93. And as you see, this was not statistically significant. And they looked at death at 90 days. And death at 90 days also was no different between thrombectomy group and the control group. And both of them were not significant. There was no significant difference. But what they found in this particular trial, the Tesla trial, is the symptomatic intracranial hemorrhage was significantly higher in the thrombectomy group at 4% versus 1.3%. And they looked at different types of hemorrhage. Right? Types 1 hemorrhage also was more in thrombectomy group as compared to the control group. Type 2 hemorrhage also was more in the thrombectomy group as compared to the control group. And even the subarachnoid hemorrhage, if you see, was significantly higher in the thrombectomy group at 16.2% as opposed to the control group at 6.2. So, which means this particular study where they took the ACA proximal large vessel infarct within 24 hours, they did not show any difference in the functional outcome. Neither did, because the last trial showed there was a survival benefit. There was a functional outcome benefit. This did not show. Although there also hemorrhage was more, here the hemorrhage of all types were more in the thrombectomy group. So the conclusions they made was in patients with the ACA infarct within 24 hours, thrombectomy did not improve the functional outcome. So very similar to the Hemotion trial and the trained randomized which went divergent. Even here the last trial and the Tesla trial go divergent. So maybe what possibly we can conclude in this is if it is less than 6.5 hours, err on doing thrombectomy with medical therapy. But if it is more than 6 point or going to 24 hours may not be very worthwhile to embark on thrombectomy is what we can deduce on the face of it. But I would leave it to the experts to dissect it out and make it more granular with regards to the clinical context they may be facing. So I think that is something that cursorily we can sort of say less than 6.5 hours, error on thrombectomy. If it is going towards 24 hours, avoid is what we can think. Okay, so I finished 4 trials, then the last trial. So this is something which is very pertinent to our intensivists. This came in JAMA. It's called Intrepid randomized controlled trial, which is to look at whether fever. See, we all know as intensivists that all patients with traumatic brain injury or subarachnoid hemorrhage or intracranial hemorrhage, they tend to have low-grade fever. So this trial was to see whether preventing that fever with acute vascular injury does lead to any good outcome. So it was basically so they used automatic surface temperature management devices. So these are the devices they used, automatic surface temperature management. Like it is like a bear hugger that we use to control. So they used that surface cooling to reduce the temperature, to maintain target temperature to see whether it influences the outcome. So here they compared fever prevention where they sort of maintained targeted temperature of around 37 degrees for 14 days versus standard. Standard is where if they had a fever, they gave a stepwise approach to control the fever with pharmacological agents, so on and so forth. But one group, they maintained targeted sort of a temperature at 37 degrees for 14 days. Primary outcome is to look at daily mean temperature burden. So this is something you need to, they've sort of, worked on their mind to do this, a bit of hard work. So what they have looked at is they looked at the area under curve of trying to determine the duration of which they have sort of a high temperature. So they calculated area under curve of temperature as the temperature that was more than 37.9 degree for duration of time. So divided by hours into 24 hours. So this is the value they looked at to determine the daily burden of temperature. That's all it is. So they tried to calculate what is the duration that they had fever of more than 37.9 divided by the timelines that they have had into 24 hours to look at the temperature burden. Secondary outcome was to look at the functional outcome at 3 months. Again, they used modified Rankin score from 0 to 6. So they took 677 patients, and this study was done in US and Korean and South Korea. 677 patients, 345 were females, median age was 62, and the type of acute brain injury they took was ischemic infarct, 254 patients, intracranial hemorrhage they took 233, and subarachnoid hemorrhage they had 200 patients. So these are the cohort of patients they took and maintained sort of targeted temperature of 37 for around 24 hours. And for around 14 days. So they had 677 patients, 339 were in fever prevention group where they used targeted temperature of 37, and 338 were in standard sort of a group where they just went to a stepwise reduction of fever. So when they looked at daily mean temperature burden, as you see, it was well controlled at 0.37. This was calculated by the duration for which temperature was more than 37.9 into 24 hours. It was measured at 0.37 degrees centigrade hour. In standard, the temperature burden was higher. This was expected. So what they said was the automatic surface temperature utility was effective in maintaining good targeted temperature up to 14 days, and they could avoid fever in these patients. That's what they found. And they looked at whether this was effective across the different subgroup of patients. So in ischemic patients also it was effective. Automatic surface temperature was effective in ischemic brain injury, was effective in intracranial hemorrhage, as you see, and in subarachnoid. So basically they said across all groups of acute vascular injury, automatic surface temperature management was effective in preventing the temperature. But the juice of the matter is whether it had any influence on the outcome, functional outcome. So they looked at functional outcome at 3 months with modified Rankin score. There was no difference. Although you maintained a good targeted temperature, did not allow them to have fever of more than 37.9, but it did not change the functional outcome. But major adverse events, there was no major difference between targeted temperature and standard. They looked at the infection risk, there was no difference. They looked at cardiac disorders, there was no difference. They looked at respiratory disorders, there was no difference between targeted temperature and the standard group. So basically it said, you may control the fever to your satisfaction in all these brain injury patients, but not necessarily it has any bearing on influencing the functional outcome is what they found out in this particular study. So it was sort of an equivocal study, or if I can say it is sort of a negative study. So the conclusion they made was in patients with any of these brain injury, acute vascular injury, either be it stroke, be it intracranial hemorrhage or subarachnoid hemorrhage, preventive normothermia with automatic surface temperature management methods definitely helps in reducing temperature management, reducing fever, but there was no improvement in the functional outcome at 3 months. So these are some 5 studies. So just to summary, the first study I spoke was this particular Hemotion trial, where it said liberal transfusion is useless. You can restrict the in traumatic brain injury. So maybe the listeners can conclude if it is only traumatic brain injury, you can afford to maintain at 7 grams. But if you have a mixed injuries of subarachnoid hemorrhage, ischemic infarct, or intracranial hemorrhage, maybe perhaps liberal transfusion, maintaining hemoglobin at 9 may be better because it did reduce unfavorable neurological outcome at 180 days, is what the trained randomized control trial showed that came in JAMA. So what for intensivists, if you are a Puritan, want to stick to evidence in TBI, 7 is good enough. But if it is subarachnoid hemorrhage, or if it's intracranial hemorrhage or ischemic infarct, maybe 9 is better off in improving favorable neurological outcome at 180 days is what we can look at. And then we spoke about last randomized control trial that was done in France group. Here also, thrombectomy with medical therapy leads to better functional outcome. For our intensive care committee, you can say if it is less than 6.5 hours, go for thrombectomy. If it is a proximal sort of a large vessel infarct involving the anterior circulation, but if it is going more than 12 hours up to 24 hours, I think the fourth study, So which is the Tesla randomized control trial, said doing thrombectomy really did not make any difference in the functional outcome. The last trial, fevers are common in intracranial hemorrhage, subarachnoid hemorrhage. So don't be overzealous in correcting temperature because it really did not, it may make you happy, but not necessarily it has any bearing on that because that is just a reactionary sort of a fever that happens with the blood in the brain or reperfusion injuries, so on and so forth. So the fifth study which we spoke about, which is the Intrepid randomized control trial, says preventive normothermia using automatic surface temperature controls temperature but did not improve functional outcome at 3 months. So these are 5 studies which I thought are practice changing and will be useful for our intensive care community. So thank you one and all. So request all our trainees to submit your valuable works to our Journal of Acute Care, which comes out every 3 to 4 months. Of course, you can visit my website to rehear to this lecture. So thank you one and all.